Hello, everyone. Welcome to the Pre-Med Scenes virtual shadowing session today with Dr. Attai. My name is Michael, and I'll be today's host. To introduce you, Dr. Attai is an associate clinical professor of surgery at the David Geffen School of Medicine at the University of California, Los Angeles. Dr. Attai is a past president of the American Society of Breast Surgeons and is a fellow of the American College of Surgeons. Also, Dr. Attai was an early adopter of social media for professional and patient education and serves as the social media editor for the American Society of Clinical Oncology Journal of Oncology Practice. Before we begin, there's a couple of reminders I want to mention. We encourage you to turn on your cameras if you're able to. This session will be recorded and uploaded to our YouTube channel. Also, there will be a Q&A at the end of the session, and you can use it at that time, but feel free to write your questions in at the time in at the chat, and we'll cover them during the Q&A. With that mentioned, though, Dr. Attai, feel free to take it away.
All right, well, thank you for the introduction, and thank you all for having me. As was mentioned, my name is Deanna Attai. I am a breast surgeon with UCLA, and I was asked to talk a little bit about, basically about my career and how I got to where I am and some of the non-surgical things that I do as well. And I start with this image of this twisty, turny road because now that I am towards the latter aspect of my career, looking back, there were a lot of twists and turns. It certainly was not a straight path from college to med school to training to where I am today. So one of the things I hope to really emphasize today is that that your career path, what you have in your head now, it may not turn out that way, and that is absolutely fine. So to start, I was always interested in science. This is me at a high school or elementary school science fair, my project on leaves, which doesn't sound very interesting now, but I managed to make it interesting, and I think I won second prize or something like that. But that interest in science, and my dad was a doctor and my mom was a nurse, so I was exposed to medicine at an early age, and I think that you know, it prompted my interest in medicine, and I graduated from Georgetown University School of Medicine quite some time ago. But I think it's important to mention that just because you have an early interest in medicine, it doesn't always mean that that's the right field for you. And some people get to medical school and realize it's not for them. And some people get well past medical school and realize it's not for them. I think one of the very, very important things, especially as you all are just starting on this process, is to really be honest with yourselves and make sure that a career in medicine is what you want, because it is, I think, one of the more challenging careers, regardless of the field in medicine, and you really, truly have to have a passion for it. Now, when I was in medical school, I was fascinated by neurology. The order of all of the pathways, maybe it appealed a little bit to my, you know, my need for order and control in my life, but I was absolutely fascinated by neurology. And so when we got to our third year, when I was in med school, the first 2 years were strictly preclinical, and we really didn't start any clinical rotation until our third year. And when we got to our third year rotations, I was really excited about neurology because I thought that's what I thought I wanted to be a neurologist. But surgery was my very first rotation as a third year medical student, and I absolutely fell in love with it. I worked with some amazing senior residents and attendings, and despite the long, long hours and really the physically grueling nature of surgery, I just was fascinated by the care of the surgical patient, how surgeons had to know a lot more than just how to operate. They had to know how to manage disease. They had to decide when not to operate. And you know, I got to the end of my surgical rotation a little sad that it was ending, although I was pretty happy about going to neurology, which was next, and I wouldn't have to take overnight call. But when I got to my neurology rotation, care of the neurology patient was very different than learning about the nervous system, during the preclinical years. And I wound up a little, I wouldn't quite say depressed, but a little disillusioned, because I was planning on using all of my knowledge of these pathways and how the nervous system worked to help inform a patient that came in with a new neurologic problem, and how do we manage that disease. And to me, it just wasn't a right fit. Partly because of, I think, the fellow that was training us, but partly because it became very clear at that time that my brain worked in a different way, and I definitely was more wired for surgery. And I think one of the another important lesson, and this talk is kind of littered with these take-home points, or these lessons learned, is that a fascination with a disease process or disease biology doesn't mean, and it doesn't always translate into a fascination with the disease process when you get to treating real patients. Now, if I had decided not to be a physician, but maybe a PhD researcher, I might have wound up in the neurosciences, again, using that knowledge that I was really fascinated by. But for me, because I wanted to be a clinician, I wanted to be a treating physician, neurology just wasn't it for me, and surgery was. And again, please don't anyone take this as a knock on neurology. It's a very important specialty. I think the take-home point really is that I realized that that wasn't for me. And even though I had kind of had my heart and my mind set on it, I was honest enough with myself to say, you know what, that's not something you're going to be happy doing for the rest of your career. And the other important point, I think, also is really keep an open mind. Because if I had gone through that initial surgery rotation, thinking of it just as a stepping stone to get to what I thought was my passion, neurology, I would not have been able to tap into some of the really amazing parts about surgery. And so going through your preclinical years, your clinical years, really keeping an open mind, there's something you can learn from every rotation. What you have in your head is what you want to do, may not be how it turns out. But if you just kind of get that tunnel vision and stick with what you originally had planned, one, you may find you're just not that good at it. Two, you may find it's just not your passion. And if you still stick with it, you're going to be very unhappy, and you're not going to take as good a care of your patient. So keeping an open mind and understanding that you can be fascinated by a disease process, but maybe not like taking care of people with that disease process, perfectly fine. But be open and honest with yourself and true to yourself. But so I did wind up going into surgery, and this was my chief year. So here I am with my graduating chief residents. This was our program director and our department chair. One of the things I will point out is no, not like my mother thought I was not on a lower step. These guys were all 5'11" and taller, and I am 4'11". So I was a little person, a little female person in what was clearly, especially at the time, a male-dominated specialty. But I will say that throughout my entire residency training, I felt nothing but support. Now, my medical school and some of my residency interviews, that's a whole different story, and I can certainly share that in the Q&A if anybody's interested in that experience. But I felt incredibly supported, and I don't think I was singled out for special treatment, good or bad, because I was the only woman in the program. When I came in as an intern, I was the only woman in the surgical training program in the whole 5 years. So from interns to chiefs, and then including those that were in the lab. So it was an interesting experience, but I really look back on my residency years as some of the hardest in my life, but some really, really incredible memories. And obviously that training turned me into the surgeon that I am today. Now, when I started residency, I really thought I wanted to be an academic general surgeon. I loved general surgery. I loved operating in the belly. This was me as a chief resident doing some sort of abdominal procedure. But I thought I wanted to be an academic surgeon because I had some great mentors, and I thought I wanted a lab and do research and have teaching responsibilities and publish papers, but also operate. But as I went through my training, we had the great fortune to rotate at a lot of different hospitals, including the VA system, including DC General, the county hospital in DC, and also 2 community hospitals. One was a little bit smaller and one was a very large tertiary care center where they did cardiac transplants and liver transplants and really everything that was done at the academic institution as well. And it was when I was at the 2 private hospitals that I really saw how different practice was if you were just a private practice general surgeon. And they had teaching responsibilities because residents and students rotated through those hospitals. But it was just a different way of practicing. And I really just fell in love with that way of practicing. And I had the opportunity to not do research. I would not recommend that. That's one thing that on some level I do regret a little bit, is not having formal research time during my residency. When I decided I wanted to go into private practice and not do a fellowship, there was an opportunity to skip the lab years because somebody was staying out an extra year. And I took advantage of that. But I will say that's one area that I wish I had had some more formal research training. So, but you can't look back. And once I decided that academics wasn't for me, I again was turning my back on something that I thought was my dream, but it turns out I didn't think I was going to be happy in that setting. And I looked for private practice opportunities when I finished my residency. Again, and this has happened multiple times through my career, and I think there's so much pressure on students and residents, and even pre-medical students, to really set your path, set your course right now. And I am a perfect example. I think I've been in 5 or 6 different practice settings. None of them are what I thought I would be when I was in your shoes. So realize it is absolutely okay to change paths, and you should change paths if you realize the path you're on isn't your true passion and your true calling. And I throw this up not to give you reading material or anything like that. You've got enough of that. But this is something that's actually been written about, and this was actually an article that was written in the American Society of Clinical Oncology annual education book a couple years ago that they published at the time of their national annual meeting. And this was geared really towards oncology fellows who are finishing their fellowship and are about to go out and get a job as an oncologist. But I think it really applies to even where you all are in the pre-medical stage, is that no decision is final and it is never too late to change course. But what you do need is to be able to recognize your strengths and weaknesses, to be able to prioritize your goals. Again, as I mentioned before, have that open mind and be honest with yourself. And then in having that open mind, you will be aware of opportunities that present themselves, even though they might not seem like opportunities at the time. Opportunities rarely come up with somebody saying, here, I have this great option for you. It's you looking around with an open mind and open eyes and saying, you know what? I wonder if I could do that instead. And then you go on the path to change. So again, I this isn't meant to just beat this kind of to death, but it's something that I see medical students and residents really struggle with in terms of, what am I going to do? What specialty and that sort of thing. And the reality is just, you don't have to struggle through this. You'll know when it's the right fit, if your eyes and your mind are open to that. So when I was looking for a job, I was very fortunate, and I think this can apply to when you're looking for medical schools or residencies or fellowships as well. Find where you're a right fit and find where you're supported. Are there mentors available to kind of take you under their wing and help you along, to point out projects that you might be interested in that you can get involved in? And that mentor can be a senior medical student, it can be a resident, it can be a fellow, it can be attending. But wherever you are in the process, pre-medical, medical school, residency, fellowship, attending, look for a place where you feel that you're a good fit. Because if you don't feel part of the team, if you're not made to feel like you're part of the team, again, this is a very challenging field. You want to make sure that there's that built-in degree of support. And these are things that you can certainly ask when you're interviewing. When you're interviewing at a medical school and you get to meet with the students, what's the culture here like among students? Are they supportive of one another? Are the faculty really, do they look out for the students here? Do they suggest research projects or things like that they think the students might be interested in? These are all legitimate questions to ask when you are interviewing and then deciding on whether it's a medical school, residency, or beyond. And my first job, I was in the DC area. And then after about and I was doing general surgery. I was a community general surgeon and I was part of a group practice. But after about 4 years or so, I started feeling, I wouldn't say unappreciated was the right word, but as the junior, I was the junior of the group. I was busting my butt, obviously, because I was trying to establish my name and establish myself and my reputation. But there were some of the senior members of the group who really were not, basically, they weren't pulling their weight. And within the group, there came a time where there was a change from the parent organization of the compensation structure, which very much favored the older members of the group and very much did not favor us junior members of the group. And, I started thinking very naively at the time that if I was working this hard, I might as well be working for myself. And little did I know. But I started looking at other opportunities, and I interviewed with a general surgeon who was in solo practice out in Los Angeles. And I think I was a little bit blinded by the sunshine and everything else out here, because there were a lot of red flags in that practice. But I took that opportunity and I moved from DC to LA. And that was back in December '99. And that practice turned out to be pretty challenging. I was very, very busy, as was the surgeon that I joined. But we had very different ideas of equal partnership. And especially after about a year and a half, it became clear that I was always going to be seen as an employee in that practice. And especially by then, I was out for about 5.5, 6 years. I was really kind of feeling like I was coming into my own as an attending. And I wanted a little bit more responsibility. I wanted a little bit more autonomy instead of just feeling like I was always the, going to be his junior partner and, sometimes just still treated like an intern. So I actually did go out into my own solo private practice. I had the opportunity. There was a colorectal surgeon in our building that I had become friends with, and we used to help each other on cases. And he allowed me to sublease office space from him for about 1.5 years till I got myself established and went out into my own office. but again, it was that trusting myself and knowing that if I stayed in this practice, I would just become more and more unhappy, because I wasn't really given the permission to do what I wanted to do. So taking that leap of faith and probably a little too much faith and not enough financial planning. That was very hard lessons, but trusting myself enough to know that, you know what, I just can't stay in this other practice. Looking back on it now, that year and a half in that practice was very, very stressful, but the only way I can really kind of put it into perspective now is it got me out to Los Angeles. I don't think I would have had the opportunities that I've had without being out here, and being in my own practice and solo practice for so long. Really, there's, it's very hard to do now, if not impossible, but there is absolutely nothing like being your own boss and making the decisions and running the show. A lot of downsides to that as well. But that's kind of the perspective that I have, even on that really rough 1.5 years, is that I can't believe I spent the first 35 years of my life living in a climate, in an area of the country where there was snow. So very happy to be a Californian now. And one of the things that I was able to do when I finally went into practice on my own, for various reasons, partly because I was a woman in surgery and there just were not a lot of us, but whether it was the practice in DC, the practice with the general surgeon I joined out here, or when I opened my own practice, breast cancer and breast disease is a big part of general surgery. And I wound up about 60% of my practice being breast. And there was a relatively young professional organization at the time called the American Society of Breast Surgeons. And I think I got a flyer or a mailer, that came from the American College of Surgeons advertising the American Society of Breast Surgeons annual meeting. And at that time, I was really starting to take more of an interest in breast disease because I was seeing more patients with it and with breast conditions, whether cancer or benign. And it was also a time when the management of breast cancer was really starting to change towards a more multidisciplinary approach from the beginning, rather than just you do surgery, then they go on to the oncologist. It was really emphasizing a team approach. And so I joined ASBS, and what I found were a lot of people that were in my situation. They were general surgeons and they were taking care of patients with breast disease, and they wanted to do a better job. But what I also found were a lot of surgeons who were a couple steps ahead of me. Like me, they had been general surgeons. Like me, they had a large percentage of their practice as breast. And like me, they really took an interest in breast disease, and they made the transition from general surgeon to a breast only surgeon. At the time, there were not breast surgery fellowships. So again, this goes back to, finding where do you fit? Where is that collegial environment, and where are your mentors? You never stop having mentors, no matter how old you are. I just picked up a new mentor 2 weeks ago, someone who's doing some research in a field that I'm interested in, and I don't have the research background, and she is helping me to write a better paper because of her research background. So you never stop finding mentors, but that's what I found in the American Society of Breast Surgeons. And I came back, I think it was from my second annual meeting, and I just said to my staff, this is the nice thing about being in solo practice and running your own business, but I just said, okay, we're switching to breast surgery only now. So I stopped doing all of the other general surgery procedures, and I basically turned myself into a breast surgeon. Never too late to reinvent yourself, right? And one of the things, again, that really attracts a lot of us to the field of breast surgery, and it's very different from a lot of other surgical subspecialties, is it's not just the surgery. Obviously, surgery is a big part of it, and especially for breast cancer. And there are procedures that are being done now that I did not learn in training. We did full lymph node removals for breast cancer when I was in training, even if there was no evidence of disease. We now do a procedure called a sentinel lymph node biopsy, where we make a very small incision under the arm and just take out 1 or 2 lymph nodes. And if those are clear, we don't have to remove additional lymph nodes. We've really gotten much, much better at our surgical techniques, whether it's for breast conservation or if the patient needs breast removal, to improve the cosmetic outcome for patients, because that's obviously a very important component, and one that was not always really paid a lot of attention to because the focus was on the cancer. Well, now we know that it's just as important not only to focus on the cancer, but on the appearance of the breast after the surgery as well. But we love breast surgery not only because of the surgeries and the advances in the field, but because of all of the other things that as surgeons we need to know and we're responsible for. As breast surgeons, we are often the first physician that a newly diagnosed patient, a patient newly diagnosed with breast cancer, will see. They'll often get a diagnosis by a needle biopsy. They're called by their primary care doctor or their OBGYN, and they're told, okay, you need to go see the breast surgeon. And because of this multidisciplinary aspect to breast cancer care, we need to know as the surgeon to at least give the patient some basic information about radiation therapy, about chemotherapy, about the endocrine or hormonal therapy for breast cancer. We need to be able to read their mammograms and their MRI images so that we can better plan our surgical procedure. Again, we're not radiologists, we're not radiation oncologists or medical oncologists, but we need to have a very good understanding of what these other specialties do, what the state of the art is. And again, be able to interpret our own imaging. And we also need a good understanding of the genetic aspects of breast cancer, because there are certain situations where, for example, based on family history, we may recommend that the patient get genetic testing to see if she carries a mutation that's responsible for the disease. Well, we need to know that before we operate because it might change our surgical decision making. There are certain types of breast cancer based on the tumor biology where we actually don't do surgery first. The patient might get chemotherapy first. We need to know which cancers those are so that we make sure that we obviously explain this to the patient, because most patients still come in thinking they're going to get surgery as the first step. That's what the understanding is. But we need to explain to them why surgery first might not be in their best interest and make sure that we get our medical oncology colleagues on board right away. This is all information that we cover in the initial consultation of the newly diagnosed patient with breast cancer. So it gets back a little bit to the fascination with disease biology. So I feel breast surgeons really have a great, we really have a great practice and a great situation because we are intimately involved, obviously, in the patient. We're the first doctor that they see. They often look to us as their primary doctor in terms of their cancer care, and we often direct a lot of the other care. We get to do the surgery, which, you know, we go into surgery because we love to be in the operating room and manage disease that way. But we also need a very good working knowledge of tumor biology and need to stay current on all of the latest treatments. So it really brings in everything. We are not just operating, we are not just counseling, we're really getting to do a lot of care, and there's just a lot of intellectual stimulation that goes along with that. And in addition, many of us have long-term relationships with our patients. So it's very different as a breast surgeon versus if I was a colorectal surgeon. Say in that situation, I would meet the patient, discuss the surgery. You know, most people are not emotionally attached to their colon like they are to their breasts. Now, there are issues if perhaps a colostomy where we have to bring the intestine to the outside is an issue. But many cases of colon cancer, it's a matter of going in, removing the segment of intestine, suturing it back together, and the patient kind of goes on their way. With breast disease, there's all of the decision making and dealing with the emotional impact of that disease. There's the treatment itself, but many of us continue to see our patients long term. And we have a much better understanding now of what has been termed the collateral damage from breast cancer treatment, the late effects of our cancer treatment, whether that's long-term depression, fatigue, cognitive dysfunction, what's been termed chemo brain. The side effects, a lot of the chemotherapy puts young women into instant menopause. So the menopausal symptoms that may occur at an early age. This picture here is what's termed lymphedema, which thankfully we rarely see nowadays at this extreme, but is a potential complication of our surgical removal of lymph nodes, and managing the PTSD that some cancer survivors really do experience. And then getting to focus on getting that patient back from a disease state to one of health, and helping her and her family get back to living their healthiest lives possible. These are some of the things that those who focus on breast surgery really, really love about the field. And it's more about whole person care. So a little bit about how I got involved on an executive level in the American Society of Breast Surgeons. You know, when I joined that organization, again, I was very new to the field of breast surgery, and I definitely felt like I found my support. I found others that were just like me, and I found mentors that would help me move my practice and my patient care to the next level. So I answered a call for volunteers. They said, you know, we need volunteers to serve on several committees. And I answered a call for volunteers. And I had been chief of surgery at one of the community hospitals. And that actually was not a good experience. There was a lot of egos involved. There was a lot of butting heads. And I didn't think that I really wanted any kind of leadership role anymore. But what I found at ASBS is, even though there were a lot of egos involved, I mean, we were all surgeons and we certainly have our egos. Really, at the end of the day, everybody was focused on what's in the best interest of the members of our organization. And I was given a project. I was part of the membership committee, which is not a high profile committee. It's a little bit of a dead end committee. In many organizations, you know, you serve your term and then usually you just rotate off. But I was given the opportunity to lead a project. It was actually redesigning the website for the organization. And that led to several other things. And it eventually led to being chair of the communications committee. And that led to being asked to serve on the board of directors. And then as my term on the board of directors was ending, I was nominated to serve on the executive committee, which means the secretary treasurer, the president-elect, and then eventually the president. So really the lesson here is, you know, don't be afraid to raise your hand and volunteer for opportunities. And even if the opportunity doesn't seem like the high profile one, it wasn't the research committee or the publications committee, it wasn't the program committee, but bloom where you're planted. You never know what opportunities might lead to. And it really comes down to, and this applies to wherever you are in your career path, do the work, you know, do what you're asked, and, you know, show up on time, do what you're asked, deliver the results on time, make yourself available. That's how you get noticed. That's how you get recognized. And that honestly is a lot of how I was able to move into that leadership role. I joined the organization in 2004, and my presidential term was 2015 to 2016. it's only about a 20 or so year old society. I think maybe now like 25-year-old society. So there are people that have been members of that organization for 25 years and have not had the opportunities that I've had. But it starts by raising your hand, and then when you're given a task, do it to the best of your ability. And also surrounding yourself by people that you can ask questions of. You know, when I was chief of surgery at the community hospital, there wasn't a lot of support. So it was very difficult to even say that, you know what, I want to continue on in leadership roles here. I want to become chief of staff. I didn't, because it wasn't a supportive environment. But you get into the right environment, and then amazing things can certainly happen. Again, this all started with just a seat on the membership committee. I had no idea that when I started in that organization as a community general surgeon, that within just a little over 10 years, I would be delivering a presidential address to 4,000 people. So again, bloom where you're planted, take advantage of the opportunities. You have to look for them. They don't always present themselves as, here, this is an opportunity. But those opportunities are out there. And then just a little bit about social media, because it is a big part of my professional persona. And I often get asked, you know, how did I even get involved in social media? Well, I initially joined Twitter because I was chair of the communications committee for ASBS. And we were looking at ways to, so this was back in around 2010, we were looking at ways to grow our profile as an organization. And we were looking to what some of the larger organizations did with social media. But in order to kind of lead that charge for the organization, I actually had to have some idea of how Twitter worked, and I had no idea. So I joined, and initially I just kind of poked around a little bit. There were not a lot of physicians online at the time, but what I found was a lot of breast cancer patients. And there were a lot of patients really talking about their disease and looking to each other for support and guidance. And what I realized where my role was in social media was, this is a way to help take the information that I share with patients one-on-one in the exam room. I can take that to a much larger audience, because one of our primary roles as physicians is to teach. It's to teach each other, it's to teach the next generation, but it's to teach and educate our patients as well. And like I said, at the time, there was a growing movement of breast cancer patients who were discussing their conditions online. And right around the time I joined, two breast cancer survivors, Alicia Staley and Jody Schauger. Jody is unfortunately no longer with us. She passed away a few years ago from metastatic breast cancer, but they took it upon themselves to form an online support community, and it's #BCSM. And this was a profile written about us in USA Today back in 2012. And this was a profile in Medscape just last year when we turned 10. We published the history of the community. And I was asked by Jody and Alicia, after a couple months of participating in the weekly chats, to come on board as a co-moderator. And that's where I am most Monday nights. We're still going after 10 years. But what I was also able to do was tap into the incredible wisdom of the patient communities and partner with patients and partner with other physicians in the online space. We went from having 1 or 2 disease-specific hashtags to publishing in JAMA Oncology about a hashtag, you know, an online communication system using hashtags for cancer care. And we've published several articles on this since then. But also partnering with the patient communities to answer research questions in ways that I had not seen addressed in the literature. So just two examples of that were when we looked at endocrine therapy for breast cancer, which is medication basically to block estrogen production and helps reduce recurrence risk from the breast cancer. One of the key findings that we found, we knew that many women experience side effects. It's been well publicized that about 30% of patients stop their treatment early. But we had about a third of patients tell us that their doctors basically either dismissed them or did not take their concerns seriously when they tried to discuss side effects with them. That's not something that had ever been published in the literature before. We also looked at the experience of women who undergo mastectomy, so complete breast removal, but don't have reconstruction. And we found that about 20% of them experience what the patients term flat denial. Either the physician says, you know what, I'm just not going to offer you that. You really should have reconstruction. The surgeon was not supportive of their decision. Or really in the worst situation, and this does sometimes happen, is that the patient and the surgeon agreed, you're going to be, I want to go flat. The surgeon says, okay, that's what we're going to do. And they intentionally left excess skin or excess tissue and told the patient later, well, this is because I know you're going to change your mind and want reconstruction later. Unless you partner with the patients in designing your research studies, and this doesn't only apply to breast cancer, but it really applies to any field. And it's not only survey studies, but any kind of research. Unless you get patients involved from the beginning, you are not necessarily going to ask questions in a way that's meaningful to patients. And you may not even be asking questions that's relevant to them. So this is a lesson that I came to late, but it's a result of the social media involvement that I've had. And what I basically did, without bragging too much, just a little bit, was that I basically created a research field. Nobody was looking at these kinds of questions before I and some of my colleagues started working in this way. And now there are many other cancer-specific online communities, not only on Twitter, but are on other social media platforms as well. And there are a lot of other researchers now looking into not only the wisdom of the patient communities, but is becoming more acceptable and more standard now to include patients in research study design, include them from day one. So again, another lesson learned is you can create your own path. I've talked about how I've changed paths a lot, but at least with my social media work and research, I've really created my own path. And yes, you can absolutely do that. And this will just a side note on social media. It's been published in no less than the New England Journal of Medicine that, one of the advantages of social media is it really levels the playing field. It doesn't matter if you're a medical student, a resident, a junior faculty, or someone like me who's been in practice now for close to 30 years. Everybody has an equal voice. If you put out good content and you show that you're a good, trustworthy, reliable person online, you will gain that following and you will gain that credibility. And so for some who may have a harder time advancing their careers, and it's not, this article was written by two women and it was focused on advancement of women physicians, but honestly, this applies to anybody who has a harder time having their voice heard. Social media is one way. Again, if you do it thoughtfully and deliberately and with just as much care as you would into treating the patient right in front of you, it can be an incredible platform and provide some amazing opportunities. And then finally, before I close, I do want to comment on burnout because it is a major, major issue. And thankfully one that is gaining more attention, but unfortunately, I think it's more hand-wringing than being able to solve the problem. Working harder is not always the answer. That was my answer for a long, long time until I wound up with some pretty significant health issues. You want to make sure whatever your outside interests are, what are you bringing into medical school? Continue those, because I basically dropped all of my outside interests. I was kind of tunnel vision. I went from high school to college to medical school to residency to attending hood to solo practice to all of this other stuff. And along the way, kind of lost some of the things that I liked to do. And when I really kind of crashed hard with some of my health issues, one of my doctors, who I'll never forget, he said, "What do you do outside of medicine?" And my answer at the time was, "I'm running my own practice. I don't have any outside of medicine." He's like, "Well, you better change that. Otherwise, you're not going to be in medicine for much longer." And so for me, my two hobbies, or, what I do to clear my head, is I've got two adorable little cats, and who still sometimes wonder who I am and what I'm doing in their house. But it also turns out that I'm pretty good at growing vegetables in my backyard, and my whole backyard now is basically one big vegetable garden. And my Instagram feed, which I didn't start until about a year or so ago, that I thought was going to be kind of a cross between some of the medical stuff and some of the garden stuff, is pretty much all vegetable garden pictures at this point, and a few cats thrown in and a little bit of medical stuff. So, again, your interest doesn't have to be social media, but make sure you whatever you're interested in now, I honestly, and it sounds silly, but write it down. Write down the things that really feed your soul, whether it's time with family and friends, whether it's exercise, whether it's gardening, whatever it is, and make sure you try and carve out time for that, whether it's in med school, in residency, and well beyond. And then finally, I'll just end with, to me at the time going through a lot of this, and I think to some looking at my career now, it really looks like one big jumbled mess. But the reality is that all of those twists and turns, they happened for a reason. And I am the happiest now professionally that I ever have been. I can't imagine doing anything but what I'm doing now. And my real hope for all of you is that despite whatever twists and turns you go through in your careers, and there will be many, and certainly a lot of valleys as well, that you wind up in my position, within, I don't know what it is, but however many years of retirement, looking back and saying, you know what, I don't think I would have done it any differently. And with that, I thank you very much for your attention and for having me. Unmute yourselves, and happy to take any questions.
I guess from here, we have a few questions in the chat that I can go
Okay.
over. I can read them to you, and
Sure.
from there you can provide any answers. Okay, that sounds good. So the first question we have is, what was your journey through medical school like?
Med school was a lot of fun. I'm always been a little bit more of a loner. I don't have a gazillion friends, and that's one of the reasons I was never on social media. I just wasn't very social. But I really enjoyed medical school. Again, I was always kind of a head down and just grind out the work type of a thing. I would say you don't have to be like that. Everybody's pretty much, if you want to graduate, you're going to graduate. You don't have to be top of the class. It doesn't necessarily help, when you're at my position. Certainly your grades and that sort of thing matters in terms of getting residencies. But after your residency match, what you did in med school doesn't really matter. So my suggestion is, I look back on all of this now, and I wish I thought of all of these little steps as more of an adventure, challenging adventures, but adventures. And I think if you look at it that way and enjoy everything about it, but again, surround yourself by people that support you, whether that's fellow students or students that are above your year, or faculty. And again, I hope you all have that same experience.
Okay. Our next question is, you mentioned that you initially went into focusing on neurology initially, and then
Yeah.
shifted to surgery. For the students shadowing today, as they go into medical school and later along the line to consider, what should one consider when trying to decide between a surgical versus a non-surgical specialty?
Well, first of all, make sure you like being in the operating room. And I know that sounds silly, but the operating room is an environment unlike any other. It is intensely stressful, but it is intensely rewarding. And as the surgeon, you are the captain of the ship. You run the show. And while most people going into medicine, to some extent, we're self-starters, right? We don't need someone to tell us to study, because you didn't get to this point by having somebody kick you in the butt all the time. But surgery is very, very different. And not everybody, it's just not the field for everybody. Obviously, you have to like working with your hands. Some of that can be taught, but some of that is innate. And you'll find that during your med school rotations when you rotate on surgery. But again, I think the first thing is make sure you like being in the operating room, and then figuring out the subspecialty of surgery, because there are so many different options that appeals to you. I think, again, just having the open mind as you go through your rotations, and just absorb it all. And then usually something will stick. It's rare that somebody by the end of their third year is like, you know what, I'm really torn between internal medicine and surgery. You either gravitate towards one or the other. But so if you think you're interested in surgery, and I've heard this both ways. One says, do your surgery rotation then as a later rotation, so you get used to what it's like in the hospital. And so you look better, you're not that July medical student on the rotation. And some say, well, do it early because you may decide you don't like it. For me, I was glad neurology was my second rotation, because I would have, gotten all the way through my third year, and then all of a sudden at the end of third year, oh man, I don't like neurology. Now what? So I was actually happy it kind of worked out that way.
That sounds great. How did you overcome gender inequality in the field when it became a problem?
So some of it I overcame by walking away from it. Realized this was, over 25 years ago. And there just was not the attention to the issues that there are today. But there are still problems, whether it's gender, race, ethnicity. These problems, you just have to turn on the news the past couple of years to realize these problems are still in society, and they are still in medicine. I think, again, now I would not recommend the walking away. I think search for the supporters, and it may be your students, it may be residents, it may be people in other programs that can help out, but search for your supporters, ask for help. And because nobody deserves inequitable, unequitable, whatever treatment just because of who they are. Whether it's your sex, whether it's your gender preference, whether it's your racial or ethnic background, any of that. Everybody deserves to be at the table. And if you are being treated in a way that suggests you're not welcome at the table, find another table if that's an option, or find the people that will help support you through that time.
Thank you for that advice. So to tag along with the previous question we had about surgical versus non-surgical specialties, when choosing your specialty in general, were you considering more personal factors, for example, a family in the future, or having a clear shift schedule, et cetera?
So there was no shift schedule when I was in training or when I first went out into practice. Residency work restriction hours were not a thing. They didn't become a thing till I was well on my way in practice. So it was, you're either in it or you're not kind of a mentality. We did our call at Georgetown as residents was every other night in-house for the first 4 years. And as chiefs, we were on call from home every other night. And we came in if there was any kind of surgery, which was, especially at the county hospital, frequent. I was also one of those who probably since high school just knew I didn't want kids. It was just not the thing for me. I would suggest taking all of those things into consideration. Again, I wouldn't recommend that head down tunnel vision, throw everything into your career that I did, because it wound up bringing me some health issues. I think you do have to think about your outside interests. And I think you all and the younger generations are certainly more in tune to the fact that your career is not everything. That was just not how, that wasn't the sort of the culture or the mindset when I trained, and it is now. And there's nothing wrong with thinking about those things. But 3 of my junior partners and my senior partner as surgeons all have kids. One of them's got 3 kids and she's a breast surgeon and her husband's a transplant surgeon. And you know what? They share responsibility and they make it work. So I think for that, it's one, making sure you find the right partner that's supportive and understanding of what a career in medicine is. And it's really a passion and a calling, not just a job. But then finding, and sometimes that does help you narrow down your specialty, say within surgery. Like for breast surgery, we don't have any night call. There's no emergencies really in breast surgery. So my junior partner that has 2 kids, most nights she's home by 6 o'clock. Not always, sometimes the OR day runs late, sometimes clinic runs late, but most days she's home at 6 o'clock. You know, if you want a strong family life and if you want dinner with your kids every night, then you're probably not going to be a trauma surgeon, for example. But so even within the surgical subspecialties, ophthalmology is another example of how there are a few emergencies, but most of the surgeries are pretty elective and you have a little bit more of scheduled work. So, and again, I think employment models are going to be very different when you all get to the point where you're actually looking at jobs where people are going to be more likely to be employed, not running your own practice. So you will often be able to negotiate your schedule and your times off and things like that.
Mm-hmm.
But it certainly can be done.
Mm-hmm. About your journey to deciding on a specific specialty, you thoroughly discussed that, but before looking into specific specialties, what motivated you to initially enter the medical field?
I think I was always interested in science, and then that's what I was exposed to with my dad as a surgeon. My dad was a cardiac surgeon, and in high school, I used to go and tag along and see patients in the office with him, and I actually watched a couple surgeries. It didn't make me want to be a surgeon at that point, but you know, it was what I was exposed to, and I think to some extent it was what was expected of me. And for me, that worked out very, very well. But this also goes back to that, you know, knowing yourself, and just because you're expected to follow a certain path, if it's not for you, don't do it. But I didn't have a lot of exposure to other things that could be done with my science interest. Like I didn't know there was such a thing as a researcher or whatever. I had a very, you know, for better or worse, I had a very narrow exposure in high school and then going into college. But there's so much you can do with an interest in science, right? I mean, it doesn't have to be medicine. But that's kind of how I went. It was what I was interested in, and that married with what I was exposed to. And you know, I went in freshman year to a liberal arts college declaring myself as a pre-med major. So, you know, like I said, for me, that worked out. It's not the way I would recommend for somebody now. I would say get exposed to as many different aspects of the area you're interested in and where you feel your skill set is, And if you're thinking of a career in medicine, make sure that that's the best fit for you.
Mhm. Okay, so our session is nearing its end. So to wrap up the session, there's just one last question we have for you. You mentioned that no matter where we are in the timeline of our career, we can always have mentors, right? From
Absolutely.
your experience, how do you meet some of your mentors and how do you go about approaching them to initially ask them for their mentorship?
Well, some of it is just introducing yourself. So if you're in med school and you have a particular professor that really seems very engaging and very interested, introduce yourself during the class and say, especially if it turns out that's maybe something that you're interested in, and, you just be honest and say, I'm looking for some guidance and I'm wondering if you would be available at some point in time to talk about, my career decisions or things like that. I mean, I know you're usually assigned an advisor, and you can certainly start out there, but anybody can be your mentor. You just have to break the ice initially. And don't be shy. This is one of the areas actually where social media can be a huge help. You may find a whole world of physicians literally across the globe that can be your virtual mentors. Nothing says your mentors have to be people that are in your actual institution. But again, it's looking for the opportunities where they are, where you can find them. You have to start by breaking the ice, and then approach them with something concrete. I'm interested in X, Y, and Z. I see that's your area of focus. Can I sit with you and talk sometime about how you got to where you are, and then, feel the person out. Not everybody's cut out to be a mentor. So you have to understand that as well. But as the mentee, you also have to bring something to the relationship as well. And it starts just by asking some questions.
Okay. So now we're nearing the end of our time. Thank you so much, Dr. Attai, for
My
taking time out of your busy
My
schedule to
pleasure.
join us today.
My email is down there. My Twitter handle is down there. If anybody has questions, you can always feel free to reach out. And I'm happy to share, whatever I can as far as helpful tips or advice or anything like that. So good luck to all of you.
Thank you. For our audience, to receive a certificate for this session, you must pass the quiz on our website, which is now uploaded. Be sure to join us next week for our next virtual shadowing session with Dr. Frazier on Wednesday, June 16th at 7 p.m. Central. But thank you again, Dr. Attai, and have a good night, everyone.
My pleasure. Good night, everybody, and good luck to all of you.
Thank you.